Sarah
Recording in progress.
Sarah is a student during the MS or
Yeah.
the MS
The
and the
MS
MS program,
FTE.
second year MS student, and
We go way back.
Danny.
Did you take the biostat course by any chance, the intro biostat,
Yeah, I took that last year
online or in person?
in person.
Oh, okay. I created the course.
Oh,
So
really?
If you
Wait, is
saw
that
it.
you in the videos?
Yeah.
That's so funny.
That's how I always introduce and talk to them, to the CGPH students, or now SGPH. And they, you take that? Ah, that was me. You saw me before.
Oh my gosh, yeah. As soon as you said that, I was like, oh wait,
Yeah,
yeah,
much
you do
longer
look
hair.
familiar.
Yeah, yeah.
That is so funny. Well, yeah, they still use all those videos even for the in-person class.
I heard, yeah. So I was like, all right.
They were helpful.
You got a lot of bang for the buck out of that course.
Yeah.
So. How are you, Danny?
Good, how are you doing?
Yeah, pretty good.
Right on.
Hanging in there, 10 years here now.
Wow,
So it's
very cool.
ridiculous.
Yeah. And working on dental caries.
Me? Yeah, oh yeah, yeah. We just finished a $13 million award from Picori.
Oh, very cool.
And that's pretty much what I'm presenting on the trial that we ran.
Nice.
So thank you. So just introducing Professor Ryan Ruff, who is an associate professor at the School of Dentistry in NYU, and you have also an adjunct or a position here.
Yeah, associated professor is what they call me, yeah.
Okay. And you were teaching here for
A lot of time,
For
number
many
of
years.
Yeah.
in biostatistics. So Professor Ruff, you have two master's degrees. Actually, I was looking
I do.
in your one in education it's actually an MPhil. What is
Yeah,
that?
actually 3 masters.
Oh.
One in teaching, one in education teaching, one in education policy, and then one in epidemiology.
And the teachings the masters in education are from Cambridge.
That's the MPhil,
Yeah,
education
the MPhil.
policy, yeah.
And then your MBA from Harvard, and then your PhD from Virginia.
Yes, sir.
In statistics.
Yep.
And now he's, as I mentioned, he's an associate professor at the School of Dentistry, where he has a pretty big research program doing clinical trials, and we're going to learn about them now. Also, I think very important, you run the core, the biostatistics core,
Yeah.
which is, I'm not sure if you will have a little bit of time to study.
Sure, yeah.
We look forward to hear.
Yeah, thanks.
Thank you.
Yeah, so great introduction. I basically classify myself as an epidemiologist and education researcher, and I'm primarily interested in school health and how schools can be vehicles for disease prevention. But because of my background in stats, I also run our biostatistics core, and you all have one now. Actually, I met with the gentleman in charge of it to help him construct his, because we have biostat cores now in dentistry, SGPH, medicine, nursing. They all have little biostat cores that have popped up. So I'm going to be talking, thank you for coming today. For taking the time. I'll be talking about pragmatic research to do sustainable medicine in schools. And the trials that we've just finished are called the CariedAway trials. So that's the hence for the name there. As just mentioned, school health, is my primary interest. And we look at how you can implement effective school health and how that affects child development, about their academic performance, their psychosocial functioning. And in doing this, we do a lot of pragmatic clinical trials. I probably do a lot more intervention work than a classical epidemiologist might do. We do a lot of clinical trials, but pragmatic trials in big, broad settings. So schools, communities, like trying to do a clinical trial outside of the really restricted clinical type research setting that you might have at, a clinical research organization or that type of thing. So a few motivating problems first. Dental caries, tooth decay, cavities. It's called the silent epidemic. It's the most prevalent non-communicable disease in the world. Billions of people afflicted by this. And it's also inequitable. Disproportionately affects children from low-income and minority backgrounds. For most of us, it's a minor inconvenience. We have a problem, we go see the dentist and we get it taken care of. But for children, adults and children who can't access care, geographic barriers, or can't afford care, or for whatever reason, they can't get the care they need, the story is much different. They face pain, they face negative impacts on their development, and that's how it translates from a nagging illness to a systemic infection that can end up killing you in certain circumstances. And despite massive financial and institutional investment here in the US over the past 20 or 30 years, we really haven't moved the needle all that much, particularly with the inequities in oral health. You see this massive increase throughout childhood and early adolescence, where it goes from a 0% prevalence, obviously everybody's fine, to about 20 to 25%. And despite these billions of dollars invested in the dental professional workforce in the country, you don't move that needle all that much. And it's larger than an oral health problem. When you have this type of disease, it has a multifactorial etiology, but it's also related to several other types of non-communicable diseases that tend to be, these multi-illnesses that affect at the same time. And it causes issues with academic performance, school attendance, 51 million hours of school year lost each to untreated oral health problems in children. We published a paper in the Journal of the American Dental Association a few years back that did a systematic review and meta-analysis of this. Basically, poor oral health is about a 50% increased chance of poor performance and school absenteeism. All right, so it affects a lot of the individual child's life. CareQuest in the US is a nonprofit, does a lot of grant work about oral health and dental medicine. And they published a grant earlier this year that had this direct quote from it. So I just stole it verbatim. School-based, school-age health programs have the potential to improve health for children and reduce disparities. And it's really nice to see the central driving focus of your work be manifested in grant mechanisms. Unfortunately, these grants are not that large. NIH, even NIDCR, tends to shy away from this type of stuff, being more focused on basic bench science. So it's a problem, but it's nice to see it really framed as using schools as a way to increase access to care for these kids that, for whatever reason, can't get it. I missed a step. What you see on here on the right, this is what's called the New York City Dental Safety Net. It's managed by the Department of Health, where I also used to work. And each one of these dots is supposed to represent a dental provider that accepts Medicaid and Medicare. All right, so free access. But it used to be far more, that's a little better over here, far better resolution. There are these wide gaps. This is Northern Manhattan and the Bronx. There are some really wide gaps in here, all right? And about 10 years ago, some colleagues in our pediatrics department did a study based off of this safety net, where they did random digit dialing for the whole list of the provider network and found something like 50% of them off the bat were no longer in service. So half of the providers on the safety net were not there at all. Of the ones that were there, about 25% of those were not accepting new patients. So the actual safety net was far less than what was being sponsored or offered by the city health department. So the premise is simple. You have kids going to school. Can you build in programs into the school itself? So again, this is fundamentally an access problem. There are 3,900 school-based health centers in 49 different states in the country that offer some type of health service. They're either state operated, they're partnerships with federally qualified health centers. Frequently hospitals or universities offer them. We have a few of them ourselves, both ourselves and Langone, but very few of them offer dental care, all right? The CDC officially recommends school sealant programs. And everyone in here has probably had a dental sealant when you go, well, maybe not some, but generally, yeah, you go see a dentist as a child, they'll put the sealant on your tooth. It's meant to block out the bacterial and protect it that way. But 65% of states report that they have a school sealant program, which is good. But only 5 report that they're able to see at least 3/4 of the schools that are high need. Okay, so less than, most of the states say they can only see 25% of the high need kids that they have. And this happened to us directly. We got reached out by school sealant program operators in Colorado saying, we get money from the CDC to go out and seal as many teeth as we can. We cannot treat anywhere near the amount of children that we need. Can you help us? And a paper was published in JADA a couple of years ago about just this issue. Why are school sealant programs not everywhere? Why are they not, just ubiquitous across the country? And it's due to increased operating costs, and particularly with dental hygienists to go out into schools. Finding hygienists to go out into schools and provide this care are seen as a barrier to implementing and sustaining school sealant programs. So clearly, the current model is not meeting the existing demand. Right? There's a gap there that needs to be filled. That really leads towards the guiding question of my research in this presentation. How can school-based oral health become sustainable? And I bucket my research into this central topic area called PRISMS that deals with clinical effectiveness studies, implementation, and optimization research, and then precision medicine. So we're doing studies and trials in all three of these individual buckets. And today I'll be talking primarily about the pragmatic trials that we've conducted in support of making it this sustainable. We'll talk a little bit about the precision medicine piece at the end, although it's much more early in its infancy and development. Just a brief history of our funding. We've had funding from the NIDCR, the NIMHD. PCORI was the big one, the $13 million award. And then additional state foundations, JSI, New York State school-based dental programs. These are all the organizations that have been interested in either helping us set up networks of school-based health programs in the country, or actually developing interventions to use in schools to increase the evidence base for what we can be doing.
Do you have a second PCORI grant?
So they gave us an additional supplementary award, which actually is part of the research I'll talk about today. After we finished the trial, we submitted another application to them to do additional supplementary analyses. And they gave us, I think it was about $600,000, just basically to fund me and a postdoc for a couple of years, or a biostatistician. But we are now hoping to also get an additional few million from them to do implementation research. Pretty much how PCORI operates is once you've completed a CER study, which is a comparative effectiveness research project, if it worked, they then are interested in funding studies that get that into practice. So since we just completed our trial, which I'll talk about the intervention we used in a moment, and showed it to be very successful, they then say, well, we're inviting you to submit an application for an implementation project, which will help you partner with everybody else to get it more into standard practice. They want to get their research translation going in that way. So hopefully that's part of the next stage of our research trajectory. We answer a number of different questions related to these studies in schools. What are the best treatments? What type of providers can do it? Who can treat the children? How does it affect child development, quality of life, academic performance? And then how much time is needed to treat? I can spend at length talking about all the individual research questions, but broad spectrum, it's all about the central focus, sustainability and impact on child health and child development. So on the clinical effectiveness side, the CariedAway trials, those are the recent trials I want to talk about. Knowing that school sealant programs are effective, but they're limited, how do we fill that particular gap? And this was the PCORI award funded this trial, silver diamine fluoride. Folks over here may have heard about it, which is silver diamine fluoride is a topical fluoride. It's literally something that you brush on, that is used internationally far more than it has been in the US. Here in the US, it has FDA status as a sensitivity medicament, used off-label a lot. Basically, what it was designed to do was if you've got tooth decay in your mouth, you paint this on, it stains it permanently black, and it hardens, and it protects the tooth from further disease development. It's been used, again, internationally. It's cheap, it's fast to use, it's efficient, and it's got documented clinical effectiveness in terms of secondary prevention. If you've already got disease, keeping it from progressing further. There was also early evidence that it was effective for primary prevention, stopping disease from happening in the first place. So we took this silver diamine fluoride and thought, can we use it as an effective complement for school-based dental programs, school-based caries prevention, basically. And there were three primary aims. What's the feasibility of integrating silver diamine fluoride into school-based dental programs? And is it non-inferior to dental sealants? So we use the clinical, if you're not familiar with the clinical trial language, non-inferior means we're just trying to show that SDF is no worse than 10% compared to sealants. So if we use the dental sealant model as our standard of care, can you use an SDF model? And if it's no worse than 10%, that's a good finding.
What is the difference in practice between the sealant, applying the sealant and the fluoride?
A lot.
Is it a lot?
Yeah. So not being the dentist, I don't want to do a disservice to the actual clinical part, but one of the key differences is a sealant has to be applied by a hygienist or a dentist. It is a specialized intervention. And in the New York Code, nurses, as silver diamine fluoride is considered a topical fluoride. Nurses can provide fluorides in New York. So that was actually a great segue into the secondary aim. Within the SDF arm of this trial, can nurses effectively provide this to children compared to dental hygienists? Okay. And then the third, what's the impact on quality of life and school performance? We were worried about that black staining on facial aesthetic perceptions. So we looked at quality of life, and then we wanted to look at, does this improve their academic outcomes?
Sorry.
Yeah.
Do they put it on the front teeth?
They can. We specifically did it on posterior application.
And is it
80%.
on the baby teeth or is it on the permanent? Teeth? So your teeth will be black forever.
Yep. That's an interesting reaction. Sometimes, because we were worried about that exact same thing. Because
I wouldn't want my kid to have black teeth for their.
you'd be surprised how many do compared to what the alternative is. So if you think of it like this, if you've got a kid in the school, all right, and I'm bouncing around a lot, so I might start repeating or skipping part of the slides in the future. You got a kid that's in the school and they've got a diseased tooth. Could be minimal, early onset, it's called the International Caries Detection and Assessment System, ICDAS. So low scores might be early white spot lesions or what have you. Could be severe. All right, what do? You can't seal it with a sealant, but you can use what's called glass ionomer atraumatic restorative treatment, which is the same composite type material of a sealant. So I didn't want to complicate things right now, but basically in the experimental arm, we used SDF, okay, which can be used to prevent new decay, we hope, or control existing decay. The other arm, you use sealants to prevent new decay, and you use sealant-based ART to control existing decay. Both on the left, on the sealant ART is a far more complex approach. You actually have to have a really well-trained method to do it. The SDF, you literally can brush it on, wait till it hardens. It does turn it black, however. So there were a couple of things. What was clinically, we're interested in what's the actual caries incidence rate in terms of primary prevention between the two, and then what's the arrest failure rate comparing for secondary prevention. Now, to get to your earlier point, if you've got a kid that's got severe disease in a highly inaccessible area, highly underserved dental area, where you can't find a hygienist or a dentist to go in and do an ART, could you have a nurse that's in the school provide SDF to that kid, knowing it's going to stain the tooth? Some parents might choose that. My son is about 2. Okay, he's almost 2 now. We see a pediatric dentist, he's got good teeth, but our pediatric dentist actually does SDF in the US. And it's a growing feature of minimally invasive dentistry. ART is meant to be a temporary restoration until you can go in and get it filled from a dentist. SDF doesn't have to have that. SDF is permanent. It's supposed to stay that way. And I would be 100%. Now, you already asked about primary teeth versus permanent teeth. That does make a difference. For some parents, for most parents, that don't have access to care, that aren't going to see a dentist, they will choose SDF for primary or permanent dentition if it avoids getting the child drilled and filled or having worse, losing the tooth, edentulous, those types of things. It is a particular individually specific case. However, I can tell you, we did apply it only to posterior dentition, primary and permanent teeth. That's where 80% of the disease happens anyway. So anterior decay, it can be a problem, but it's much more rare. We treated over 7,000 children. We did this trial also in New Hampshire, funded by the NIH, so actually over 10,000 children. And we never received a single adverse event or a complaint from a parent about the staining. For them, it was about treating the disease rather than having the irreversible black staining. Clinicians now are using it more and more across the United States in their actual clinical practice because they can say, we can brush this on. You don't have to get a drill. You don't have to get numb. We don't have to drill it away. Even with the black staining, a lot of adults are choosing it because it's minimally invasive. There's no pain. There's no time out of that type of thing. So, but it is individual. It's patient specific. So we had the big table 1 of the trial is there on the right. We had excellent prognostic balance. This was a cluster randomized trial. We did it in 48 schools in New York City, particularly looking at schools that have a high proportion of children from Hispanic, Latino, or Black race ethnicities, and high proportion of the school of low socioeconomic status, Title I, getting free and reduced lunch, basically. So excellent balance. This is basically how we set things up. This is silver diamine fluoride on the top left. On the top right is what our clinicians call a burrito. They basically wrap all their things up into a single disposable cover that they can then use, 1 burrito per patient, and they toss it out. They don't even need dental chairs. They have lap boards that they put on, and so they can set up in a hallway, an auditorium, wherever it needs to be. So wherever the school has space, that's where we roll in. This person here is a hygienist. There's a dental assistant behind her, and then the bottom right, that's a nurse. Okay, so they were setting up. So again, is SDF non-inferior to sealants and ART in the primary and secondary prevention of caries? How do nurses compare to dental hygienists? How does it affect quality of life and educational performance? Those were the 3 primary objectives of the trial. Last year, we published our first paper. We looked at primary and secondary prevention after 2 years and after 4 years. Those were the 2 time points that we had proposed. So we published in JAMA Network last year about the 2-year comparison. This was a little disrupted by COVID. We were in schools for about 6 months to 9 months, depending on when we started that school, and then COVID shut us down. We actually got extremely lucky that schools opened back up 2 years later. So we were supposed to be going in every 6 months to do observations over that 2-year period. That we lost. When COVID shut down the schools, they shut them down for all school-based healthcare providers that were operating in the city. So even when schools reopened for academics, they did not reopen for medical care until 2 years after their initial shutdown. So we were still able to keep our timeline, but we just had beginning and end. We didn't have the intervening observations that we were hoping to rely on. But we looked at kids that didn't have decay at baseline and looked at how many of them stayed decay-free 2 years later. Of the kids that had decay, how many of them stayed controlled, which we call arrested, after 2 years. We found that the prevention rate of new caries was virtually identical. This is our non-inferiority graphic here. Caries prevention, the difference was 1%. About 80% of kids in both groups stayed disease-free after 2 years. In the arrest group, the SDF kids, about 56% of them stayed controlled, and 46% of the ART kids stayed controlled. So SDF performed better after 2 years by about 10%, both of which were statistically non-inferior. So this was an excellent finding for our project. Published earlier this year in JAMA Pediatrics, looking at 4-year caries incidence, so the cumulative incidence of disease that was observed. We found, again, almost identical findings between the SDF and the sealant ART group. It was about 10.2 diseased teeth per 1,000 tooth years in the SDF group versus 9.8 in the sealant and ART group. And then we modeled this in a few different ways. This was just a pure raw, risk rate. We also looked at it through, conventional mixed effects longitudinal models and saw that whether we're looking at caries prevalence or caries incidence, there were no differences. Both improved over time. The per visit risk reduction was statistically significant in both groups, but there were no statistically significant differences between the treatment and the active controls. And it once again was considered non-inferior. We are just about to submit to Lancet on the 4-year arrest. What we found here is within the SDF group, there were about 7,500 surfaces on the teeth that received care for existing decay. So there were 7,500 and change diseased surfaces in the SDF group versus 6,600 in the ART group. Of those treated surfaces, disease surfaces, we had about 2,500 failures in the SDF group and 2,100 failures in the ART group. So about a 32.5 versus 32%, almost identical failure again. And when we consider the time of observation in person years and we look at it, the incidence rate is again virtually indistinguishable from one. So no differences between the two whatsoever. That's the primary objective taken care of. The secondary objective was again looking at nurses versus hygienists. Within the SDF group, how do children treated by nurses compare to those that are treated by hygienists? Okay, so we couldn't do this in the sealant ART group because nurses aren't legally authorized to do so. This was a non-randomized piece of the study. Okay, this was first come, first serve in the school. We don't think there was anything that introduced any systematic bias into this selection. It was whatever child was next and whatever clinician was free, that's where they went. There wasn't any particular ordering. But we published last year in Community Dentistry Oral Epidemiology, again, after 2 years, and then we're hoping to publish soon after 4 years. Again, virtually identical between the two in preventing new caries. So the kids that didn't have decay for primary prevention, identical numbers between nurses and hygienists, whichever they were treated, right? That's an easier one. There's no disease to identify and treat. But when we look at it for arrest, things actually look better for nurses. Somewhat surprisingly, the failure rates were lower. The 4-year failure rates for secondary prevention, caries arrest, were lower in the children treated by nurses, about 24%, compared to 35% in hygienists. So nurses did about 10% better. This is actually pretty important because there's a growing interest nationwide in expanding the use of SDF in primary care. There were a couple of papers published in JAMA earlier this year by the US Preventive Services Task Force about oral health screening and prevention for oral diseases by primary care providers. So not dentists, literally physicians and nurses in the office. And they cited our research from JAMA Peds and JAMA Network and said, this is great. However, there's still not a preponderance of evidence because it was non-randomized that we want to do this. We can't officially recommend it being part of their portfolio. However, there's now a CPT code, a reimbursable code for primary providers to do SDF in their practice. So this is further evidence on that side that nurses can certainly do this. We didn't look at physicians, but nurses are certainly capable. Yeah.
Do you have any insight as to why they were better?
We were talking about this exact thing today. So our clinical director of this program, Tamarinda Berry-Godin, she is a pediatric dentist and a dental public health specialist, and she also has an MPH. And her theory is that because this is not something that's normally part of their professional practice for nurses, they are particularly focused on doing it very well. Whereas compared to a hygienist, it might be interesting to have you guys' perspectives as well, the hygienists sort of view this as, it's the wrong terminology to say they view it as beneath their professional capabilities. However, they're trained to do sealants, more complex procedures, so they don't focus as much on effective SDF application. That makes logical sense to me. You know, if you teach me something new and I don't want to mess it up, I'm going to be very careful about it versus if you ask me something I consider myself an expert in, I might just be a little less focused. But she's not really satisfied with that theory, or at least how it's phrased. So we're currently wondering why this might happen in general. Yeah, beyond.
Well, it seems that if it got moved into routine practice for primary care providers, you would have regression to the mean then. If it became less novel, then maybe their outcomes would be similar to the dental outcomes.
It is a possibility. Yeah, yeah. So we don't quite know yet. You know, there are certain things we'd like to look at with this that we can't. Arrest rates could vary by the severity of the disease, by how severe the actual disease is on that particular surface. We didn't use that as a criteria. All we did was, if it had a score of 5 or 6, it was considered disease, but we didn't record which score it had. So because it was non-randomized, there may have been variation in the severity of disease that the nurses happened to see. We don't know. So yeah, that's a good question. And that was the second objective. The third objective, academics and chronic and quality of life. Academics was probably the objective, not probably, absolutely was the objective that was most negatively affected by COVID, because the schools suspended all the standardized tests that were being offered, and instruction went to Zoom, which attendance was very haphazardly recorded during that time. So we weren't even able to look at standardized test performance. We did publish a paper in JADA that looked at chronic absenteeism, which was the proportion of children that missed 10 days or more. And we seemed to find that in years that the program was operational in the school, chronic absenteeism would drop by 3%. But if we adjust for the COVID impact, this does disappear. Okay, so we published it because it's still interesting, but the jury's still out on this one, and we're hoping to do a lot more follow-up studies on this particular thing. It may also be much more downstream. You may not see immediate effects to this on chronic absenteeism, but as you continually treat more and more of the underlying disease, attendance may improve. So something to look at. Quality of life. In a random subsample of both of our treatment groups, we administered a quality of life scale. And this particular quality of life instrument did include questions related to facial perception, facial aesthetics on the child. And overall quality of life improved in both groups just by treating the underlying disease. And there were no differences between groups in quality of life, right? And no direct appreciable impacts on aesthetic and self-image as well. So whether it was the fact that we did posterior application or they were just happier to know they had dental care rather than, we had one child, I'll get exactly to your question. We had a child that had 16 teeth that had disease, including 7 or 8 anterior. And the child asked us in the chair if he could have the SDF put on the teeth, knowing it turned to black. We couldn't, of course, because it was not on the protocol or consented, but that's the type of thing that the kids are starting to face. You know, it's.
I wonder what it would be when they hit teenage years. Like a 6 or 7-year-old will be like, my teeth hurt, I don't want to deal with this or whatever. But then you get to the age where you're looking for a partner, or boys and girls matter and your relationships and whatever. Then I wonder if it would matter.
It might. I mean, we focus on 5 to 13. We have had interest in looking at the adolescent, middle school, high school years. I haven't looked at this, but I imagine it's probably done internationally. I mean, we did an SDF study in the Philippines where the caries prevalence was 98%. Now, again, we did our study in primary care, but I'm certain if there is research out there on the adolescent years, it's going to be that type of thing. And again, you got to think about, you really got to think about the context that we're doing this. For us, for me, I'd say, no. Just give me the standard drill and fill method. But we're talking to folks in rural Appalachia, you know, where my family's from, where there's not a dentist within 50 miles of anybody. And even if there were, they couldn't afford it. So for these types, you're right, when they start to mature, their perceptions about what matters to them may change. But at the same time, think of the alternative. So it changes the narrative. It changes the perception about what's relevant or not in that type of situation. And dentists are starting to use this as saying, yeah, it turns your tooth black, or not the tooth, it turns the demineralized portions black. It's not like the entire tooth turns black. That's telling us it's working. You know, if it's like that, that means it's worked. We've stopped it. You're not going to have any more problems. And that's actually turning out to be a viable approach to dentists that are using this more and more in their practice. Yeah. So based off of this, you know, I mentioned we did that. We received that follow-up award from PCORI to look at some sensitivity analyses. So we started thinking about optimization. How do we now start to move this towards where this could be a sustainable approach? So I won't delve too much into the math or the research behind this, but we did do a few studies looking at things like transition probabilities. If you think about a tooth as a three-state Markov model, it's either healthy, it's carious, or it's arrested. It's either sound, has no problems, it's got a decayed spot on it, and then it's managed. And what are the probabilities from bouncing between those two states? So we can go from sound to arrested, carious, we can go from carious to arrested, we can go from, you know, back and forth in certain circumstances. That's our three-state Markov model right here where you could go, and just estimating the tooth and individual level probabilities. This was just to identify, are there certain teeth that are more or less susceptible to disease transitions? And we had central incisors, first and primary, secondary molars. Again, all the numbers are out there. This paper's on medRxiv to show the individual state transition probabilities that are out there. Other one, which was largely an academic interest for me, was an interest about interval censoring. Almost all school-based dental programs in the country operate on a biannual or an annual basis. They go in every 2 years or every 1 year, and they diagnose and they treat appropriately. That causes issues with interval censoring, and the epi folks will know how big of a problem this can be. You know, all you may know, unless you've got extreme, you know, fine-grained follow-up schedules, is the point where the last observation where it wasn't diseased and the point in which it was, okay? Affected by COVID, this was even more problematic because we had some patients that we had a 6-month gap. We had some patients that we had a 2-year gap where we knew that the disease happened somewhere. So we used a method, G estimation, to estimate the hazard of disease, basically, in the presence of interval censoring. And then we used G imputation to impute infection times based off of a list of covariates to get us towards estimating what might the annual incidence may be, tooth level incidence or individual level incidence at each subsequent biannual observation. Just to be able to tell us, all right, under these certain circumstances, if we can't go in at this period or we have resources that may want us to go in a later date, how much disease might we anticipate in these types of populations? That's what this one is. The last part of the optimization was time. We used proprietary electronic health records to do our data collection and our clinical exam storage. And we had timestamps for each part along of our protocol. And we wanted to see how long does it take to treat children in the experimental group compared to the active control. About I'm trying to think about, I think overall it was about 8 minutes shorter to treat children with SDF versus sealants and ART. That's whether it was primary prevention or secondary prevention. Over time, longitudinally, that was a baseline, just an initial treatment, because that's where the disease was going to be the worst. Over time, the groups tended to get a little closer together. So the sealants, we applied SDF every visit. Sealants only got applied again if they fell out. So over time, the groups started to equalize, but certainly for that first visit, about a 50% reduction in the amount of time that was required to treat the children. And this was statistically significant. This is also at medRxiv. Last few slides here talking about precision medicine and implementation.
Before you
Yeah, sure.
So if people are going to do this outside of a research setting, is there a big difference in cost?
Outside of research, difference in cost? Yeah, actually, hang on. So when we first published this in Peds in Colorado. I mentioned about 15 or 20 minutes ago that someone in Colorado reached out to us. This is them. They said, we've read your SDF research. We have a school-based sealant program. We have 16 or 17 schools. It's really problematic. Our schools are 60, 70 miles apart from each other. We have to haul a trailer 4 feet by 6 feet through the Colorado winters, which isn't all that viable. We have heavy equipment. We can't afford the money that CDC doesn't go far enough. We'd like to be able to integrate SDF. We said, this is freaking great because this is exactly what we want to do now is proof of concept in the research, now moving it into practice. So we did a pilot with them where we developed an implementation toolkit, provided interactive technical assistance, and we trained them to integrate SDF into their existing care practice model. And we just sent this on medRxiv last week, I think, actually, because they collected the data on program operations. So we did an implementation, process evaluation. And this is what we found. They had a 53% decrease in the per child treatment time, 23% increase in the number of patients that were served, 100% increase in service measures because that's how they add SDF into their sealants. 45% decrease in labor costs despite the increase in patients served, and a 24% decrease in supply costs. So from 1 year to the other, the year prior, they had their sealant model, and then they added SDF into it. They triaged patients by whether they were considered high risk or low risk for future disease, and then treated them with this SDF or sealants or a combinative approach as appropriate. And because of that, they saw about 300 more children that year, and the per person costs dropped precipitously because of that. So this is the case study that we've used in our application to PCORI and the NIMHD to fund the implementation of this. Knowing this as the exemplar, being able to implement this in practice with technical support, can you now roll this out? So we have partners now in New Jersey, New Hampshire, Colorado, and Virginia that have signed on to participate in this implementation project if we get funding for it. And it basically looks like this. This is what we proposed, a stepwise cluster randomized trial design to phase in SDF into existing care practices. Some of these programs are sealant programs, some of them are fluoride varnish programs, some of them are screening programs. All of them have no SDF to begin with, and then they'll transition into a post-SDF implementation period. That's pretty cool. That's what we're hoping. We're hoping I think this is great. I mean, who would not want to fund this? But maybe
This is very cool.
maybe the other folks don't. I don't know.
Maybe you want I'm not sure if the students are familiar with the step wedge designs. Maybe you want to say a word?
Yeah, so a step wedge design is another pragmatic type of trial design. Again, that's what I tend to focus on. And you have different waves of entry, and it's called step wedge because you imagine like you're stepping down a stair. So you've got, observation, pre-implementation period, implementation period, post-implementation period. So you've got one, and then you step down, and then step down, and then step down. So each group gets the treatment eventually, and then you've got periods of pre-implementation and post-implementation. Yeah.
Ryan, one question. The previous trials that you have done, they were not cluster randomized.
They were, yeah.
They were cluster randomized.
Yeah, because they were school assigned.
Okay.
Yeah.
And then the analysis was per surface, or how did you ended up doing the analysis? Now taking the advantage of your statistics.
Yeah. So it depends on the paper. The JAMA network paper was at the individual level. So we considered failure anywhere was failure everywhere. Now that's a very conservative approach. But so our analyses there adjusted for school level clustering using sandwich estimators basically. The JAMA pediatrics paper was tooth level. So we adjusted for, it was a 3-level multi-level model where we adjusted for schools, individuals, and teeth, observations nested within teeth. The paper that we're hoping to go to Lancet soon, the 4-year arrest was surface level, which were simplifying things in a way. We're ignoring, what we basically found is you can practically ignore the school level clustering. The interclass cluster correlation for the school leveling, at least in these trials, was less than 1%. So there's basically no appreciable design effect on your sampling. And the variance, the standard errors don't really get affected whatsoever. So the surface level analyses we did crude rate ratios, and then we did some simple binomial regression models where we did adjust for school. And now we're doing recurrent event frailty models because we can allow for surfaces to fail more than once. So we're doing multiple event survival analyses where we are just at that point adjusting for repeated observations because we're just treating schools as a non-factor at that point. Yeah. Yeah, which was good because our actual initial power calculations wanted us to have 14,000 children because we assumed a very liberal ICC, about 8 or 9%, if I recall correctly, and we could not get that many because of COVID. So we only got 7,500, but it wound up being far more.
And how many clusters, those 7,500, how many clusters in how many schools?
48 schools.
48.
Yeah. Really, I got about 5 minutes left, I think. The last bit is the last part I skipped over, which is, the precision medicine piece. One of the things we're sort of observing, no matter how often we do this, and we've done studies in Colorado, Massachusetts, Maine, New York, New Jersey, New Hampshire. There's always a subset of kids that always fail, no matter what treatment we use. Sealants, ART, SDF, fluoride varnish, they always fail. And thinking about why that is, there's a lot of things, it's almost entirely out of our control. We go into the school, we see the child for 10 minutes, and then we see them 6 months later, a year later. They've got diet problems, they've got hygiene problems, they've got cultural factors that may be impacting it. So what we call this treatment non-response. And we started to look at first thing we was like, what's the etiology of treatment non-response? We got an R56 award from the NIDCR to look at the microbiome of non-responders, and we saw certain bacterial species were elevated and a greater prevalence in non-responders compared to responders. And we were actually able to build a neural network to predict this. This was pretty cool going down the line, but it's really an academic exercise. You really can't use this chair side. You're not going to have a point of contact microbiome analysis of kids to know whether they are or are not at risk. So what we're also proposing as the next step for our clinical effectiveness studies is what's called a sequential multiple assignment randomized trial. And this is getting at adaptive preventive interventions. You can treat a child with an initial intervention, and then depending on whether they responded or not, modify their treatment pathway based off of their non-response status, their socioeconomic factors, their hygiene based off that, if you have that as a data point for their survey, where you get at non-response. This is an entirely different perspective than our classical approaches to school-based care, which is basically treat everybody you can as often as you can. These are for the ones that don't respond. So it's about being able to modify. It's a far more specialized approach, and it's not going to be anywhere near as sustainable, but it does help move the needle for those kids that don't respond to care. Based off of that, that's where we're at. This has been the culmination of a 6-year clinical trial process, and we're now hoping that we can translate this into a sustainable model that can be used nationwide as appropriate. I've always been very careful to frame this as complementary, not supplementary, not replacing the existing sealant approach, because that's if you have the resources, if you have the capability, if you have the access, that's what I would recommend. But in situations where you don't, or you need to offset certain logistical challenges to be able to make sure that you can see all of your at-risk children, this could be a very viable complement to increase the capacity of your program, which we saw in the implementation model. And that's it. Thank you.
I just have one comment, like, it's amazing what this chemical can do, but it's so unfortunate that it basically stigmatizes you for being poor for the rest of your life, because now there's a visual and physical manifestation of your childhood poverty, because particularly if it's on your permanent teeth and it's been done in the front. And I'm just wondering are there any other alternatives under development that would be less staining? Like I have an issue, I'm allergic to iodine and contrast dye. So like I can't have studies with contrast because I'll go into cardiac arrest. So if I ever have a heart attack and then need to do a cardiac catheterization, I have no idea what they're going to do for me. And I feel like this is a very similar situation where you have this like almost miracle chemical that will arrest these cavities and the decay, but the consequence of it can be, you know, devastating for some people, just particularly if it's in the front. Like I could see in the back. Like I would almost be like, ooh, I kind of want that in the back, right? Nobody sees my back teeth. That doesn't matter. But I looked at some pictures of what happens in the front. It makes your teeth look rotten from a non-dentist perspective.
Well, so to make some clarifications there, they were, believe me, they looked rotten to begin with.
Yes, no, I understand.
And those are certainly severe cases. And again, 80%, it's the old 80-20 rule. 80% is found posteriorly anyway.
Yeah.
So you're automatically lopping off wide swaths of the population that has that possibility. It's very easy to think about it as a cross of the scarlet letter of low SES in that regard. However, that's also how I've been framing it because of this conversation, because we focused on low SES, because those are the ones that traditionally lack the access to the care. There are providers. Jeremy Horst is a great one. He was at UCSF for a while, and he pioneered a lot of the biological research as an FCF. He's a clinician who's just recently opened his new practice about using minimally invasive approaches for adults, including SDF. Because again, if you ask an adult, you know, like during COVID, I had an implant fail and I was walking up and down Fifth Avenue. It was like, I am legend. There was nobody on Fifth Avenue except me. And I had to go see a dentist 4 times in 1 week. And I'm like, man, if there was something they could just slap on there.
Oh, I feel you. I
I would
had
take it in a
teeth
heartbeat.
cracked during COVID, so.
Yeah.
It was horrible.
You know, so it's what you're comfortable with in certain circumstances, you know, will change and tastes will change, as you say. To your point about the active research, it is trying to find a way to minimize the staining effect. It's interesting you say iodine, actually potassium iodine is one of the ones that they're trying to combine with SDF to do that. I don't recall it making much of a big difference. There's silver modified ART, which is where you apply SDF and then cover it with the ART method, basically combining both, which tends to lighten it a little bit simply because you're adding another material over the SDF, but not an appreciable amount. I'm sure whoever does come up with it will have $1 billion, idea.
Yeah.
Can
Can you get veneers on top of those, like once they're stained?
I don't think so, because you have to,
You need to treat it like it's an invasive procedure to put on veneers.
yeah, you gotta grind away
Yeah.
what's currently there to get the veneer on
You
there.
need to disturb the tooth to fit in veneer.
So there's nothing with cosmetic dentistry later on that you could be done, or?
Not to my knowledge.
So you're, oh, wow.
No, like I am from India, so we use something called APF. So it's like acetate phosphate.
Oh, yeah.
Yeah, so APF doesn't like stain your teeth at all. But comparatively, I think HDF is better in progression, but we use APF, like it doesn't stain the teeth.
Yeah.
It's a pretty good alternative, but I don't think it prevents you as much as what HDF.
And this is a very interesting conversation that we're having, because what we're replicating is conversations that I wind up having with dentists. Some of the dentists are not happy with this type of research because it's taking money out of their pocket or taking procedures that they would normally do. The chair of our own pediatric dental department, who's the former president of the American Academy of Pediatric Dentistry, is not against this, but has explicitly stated, I really don't feel comfortable with nurses doing this type of thing. And from my perspective, the conversation we're having right now is reflecting an individual case-by-case basis, and one that a dentist is going to be thinking about. And maybe being the luxury of a non-dentist, this to me is not a dental problem. This is a public health problem. And similar towards large, wide-ranging public health problems, thinking about big public health solutions. So I have the luxury of leaving some of those questions to the clinicians and thinking about, we have a rampant pervasive disease where if a clinician reads this research and says, no, you need to bring them into the office, they're not going to the office anyway.
Yeah.
So how do you increase care to this population that the needle is not moving, they're not availing themselves of the current resources that are there, and this is the side effect, and it's an aesthetic side effect, which so far we've encountered very little evidence actually matters compared to the alternative. So treating it as a public health problem, as an epi problem, this is one of those solutions. And that's exactly what, coming full circle to how I view this, schools as a model. There are over 186,000 school nurses in this country. That's 75% of the entire dental hygienist workforce. Now, there's a lot of work to get there. This implementation project is about getting existing school-based programs to integrate SDF into their practice. I want to get to the point where nurses in the school can do this without relying on external providers, because that happened to us. Once the funding's out, you're done. We treated 48 schools in New York, but when the funding ended, we stopped providing care to 48 schools because we just simply could not afford to do it anymore. So integrating it is half the battle, like the Colorado experience has showed us. But if you get to a point where the nurses in the school, that's my sort of dream goal. And I'm going to make a lot of enemies getting there, I'm sure. Being able to do that. If you look back 100 years in New York, nurses had a lot more power in schools. They were responsible for infectious disease control. They could follow up with primary care providers, go see children at their homes, do examinations. So when you talk to nurses, new nurses, they're very interested in including, the new nurses that are coming out now view children as the school nurses, that these are my kids. I'm responsible for their entire health and well-being. Give me the opportunity to also take care of their oral health. So you're seeing oral health education, prevention, promotion in nursing practice now. It's becoming a larger process and a larger movement. So this is what we're also hoping to move into them as well. Thanks again.
It's really good.
Yeah,
That's
that's so interesting.
Thank you so much.
It's just amazing that it's such a big fix for such a serious problem.
Yeah.
Like, and simple, like really straightforward.